Although only a few diseases affect the stomach, they can be very serious and in some cases life-threatening. The most common disorders include gastritis, peptic ulcer disease, and gastric cancer. Prostaglandins provide a protective mucosal barrier that prevents the stomach from digesting itself by a process called acid autodigestion. If there is a break in the protective barrier, mucosal injury occurs. Hydrochloric acid can then diffuse back into the mucosa and injure small vessels. H. pylori can result in acute gastritis. It penetrates the mucosal gel layer of the gastric epithelium. Gastritis is the inflammation of gastric mucosa. It can be scattered or localized. It is classified by the cause, cellular changes, or distribution. It can be erosive or non-erosive. In the acute phase, it's thickened, reddened mucous membrane with prominent rugae or folds. If the stomach muscle is not involved, healing occurs in a few days. Chronic gastritis is patchy, diffuse inflammation of the mucosal lining of the stomach. The walls of the stomach thin and atrophy sets in. Parietal cell function is lost. Pernicious anemia results. There is an increased risk of stomach cancer. Long-term NSAID use creates a high risk of getting gastritis. Some other risks include alcohol, caffeine, corticosteroids, corrosive substances, emotional stress, and/or anxiety. Acute gastritis includes a rapid onset of epigastric pain, nausea, vomiting, hematemesis, hemorrhage, dyspepsia, anorexia. For chronic gastritis, we have type A, which is associated with the presence of antibodies to parietal cells and intrinsic factor, and we have type B, which is most common and is caused by H. pylori. There is a vague report of epigastric pain that is relieved with food. They have anorexia, nausea and vomiting, intolerance of fatty or spicy foods, pernicious anemia, atrophic gastritis, which is seen in older adults and its exposure to toxic substances. You want to limit caffeine, chocolate, mustard, pepper, and other strong or hot spices. Avoid alcohol and tobacco. Have them eat a well-balanced diet, exercise, and teach them techniques to control stress. And then you want to have them avoid NSAIDs, aspirins, and steroids. Okay, so to recap, some clinical manifestations, they can range from mild to severe. They can have epigastric discomfort, anorexia, cramping, nausea and vomiting, abdominal pain after meals. You want to assess for abdominal tenderness, bloating, hematemesis or melena, heartburn, anorexia, and in some cases, gastric hemorrhage is the presenting symptom. So labs and diagnostics include to detect H. pylori, like immunoglobulin G or immunoglobulin M, anti-H. pylori antibodies, Alecia, and immune chromatography. That's done by a finger stick, and then a breath and stool analysis. Know the details of these tests. EGD is done by an endoscope with a biopsy. This is the gold standard for diagnosing gastritis. And then we had the rapid urease testing. Acute gastritis is treated symptomatically and supportive because the healing process is spontaneous. Transfusions may be necessary if the bleeding is significant. IV fluids are used to treat fluid loss, and if there's a major bleeding, surgery may be done to remove part of the stomach. For chronic gastritis, treatment is to figure out the cause and eliminate that cause. These patients will need vitamin B12 for prevention and treatment of pernicious anemia. Medications will include such as Pepcid, Axid, and these block gastric secretions. There's also Carafate. It's a mucosal barrier fortifier that's often used. There may be antacids that could be thrown in the mix, as well as PPIs. You want to have them avoid NSAIDs, corticosteroids, erythromycin, because they irritate gastric mucosa. And then for diet, have them avoid spicy citrus foods, alcohol, and or tobacco. Now we're going to talk about peptic ulcer disease. This is a mucosal lesion of the stomach or duodenum. It results when the mucosal defenses become impaired and they no longer protect the epithelium from the effects of acid and pepsin. So this starts out as a gastritis and then progresses to an ulcer. Mucosal lining of the stomach or duodenum is damaged and can no longer protect the delicate epithelium from the stomach acid and the pepsin. Most gastric and duodenal ulcers are caused from H. pylori infection, which is transmitted by the fecal-oral route, usually during childhood. It can also be spread through contaminated endoscopic equipment. 50% of the world's population has this. What happens is that the H. pylori bacteria secrete urease, which produces ammonia and changes the environment from acidic to alkalytic. Hydrogen ions are released in response to the ammonia, and that just further damages the mucosa. Lab tests can be done to detect presence of urease. With gastric ulcers, it is simply the diffusion of acid back onto the sensitive mucosa that damages that epithelial tissue, or there could be pyloric sphincter dysfunction. If the sphincter doesn't work well, then bile from the gallbladder can reflux, and then the bile damages the mucosal lining. Furthermore, these patients often have delayed gastric emptying, which only further damages the mucosa. Decreased blood supply only further complicates things because it alters defense mechanisms. Duodenal ulcers are very deep, sharply demarcated lesions that go through mucosa and submucosa into the muscle layers. Floor of the ulcer is necrotic on top of granulation tissue and surrounded by areas of fibrosis. The hallmark characteristics of duodenal ulcers is high gastric acid production. pH levels are low in the duodenum for long periods. Protein-rich meals, calcium, and vagus nerve excitation stimulate the acid secretion. Combine that with rapid emptying of the stomach contents and means there is a bolus of food in the duodenum and a lot of acid. Most people with duodenal ulcers had the H. pylori infection. Okay, so let's talk about stress ulcers. There's different types. We have the Curling's ulcer. This is the ulcer that burn patients get. With sepsis, there is a ischemic ulcer. With head injuries, we have Cushing's ulcer. These can occur simply if a patient is NPO for surgery. Main manifestation of these ulcers is bleeding. Okay, so let's talk about some complications of ulcers. Causes are primarily associated with NSAID use and bacterial infection with H. pylori. Hemorrhage, perforation, pyloric obstruction, and intractable disease. Hemorrhage is the most serious complication. Then we have hematoemesis, which is bright red or coffee ground blood in emesis. Then we have melena, which is occult blood and tarry stool. This occurs when the ulcer is so deep the entire thickness of the stomach is worn away. Contents leak into the peritoneal cavity. Vomiting bright red or ground blood is when the ulcer is probably above the duodenal-jejunal junction. That's an upper GI bleed. There's minimal bleeding that is usually seen with tarry stools. If the ulcers go all the way through, then peritonitis can develop. Symptoms include sudden sharp pain, apprehension, rigid board-like abdomen. The patient will assume a fetal position. Peristalsis diminishes and paralytic ileus develops. This is a surgical emergency. Pyloric obstruction occurs rarely. It's caused by edema, spasm, or scar tissue. Symptoms are related to difficulty in emptying the stomach, which include feeling of fullness, distension or nausea after eating, as well as vomiting copious amounts of undigested food. Treatment is to restore the fluid and electrolytes and decompress with nasogastric suction. Most patients have ulcers one time and then they don't reoccur. Risk factors include family history, NSAID use, H. pylori infection, and the same risk factors as for GERD. So for our nursing assessment, we will perform an epigastric tenderness, check for that, dyspepsia, nausea and vomiting, gastric pain. It's usually in the upper left abdomen, left of the midline, and it's aggravated by food. Duodenal pain is on the right upper abdomen. It occurs about 90 minutes to 3 hours after eating, and the pain will become worse by eating certain foods. H. pylori doesn't survive in stool, but an ELISA test may detect its presence. So when we look at the labs, the H&H values may be low, the stool specimen may be positive for occult blood, and H. pylori may be present. For imaging, an EGD is the most accurate. Direct visualization allows specimens to be taken for H. pylori. Cytology studies rule out cancer. For interventions, we're going to manage hypovolemia. We may possibly infuse blood. We are going to monitor for shock. For NG tube placement, it's done for lavage. They insert the NG tube. The purpose is to determine the presence or absence of blood in the stomach, assess the rate of bleeding, prevent gastric dilation, and just basically to administer the lavage. For EGD care, we're going to have an IV going. We're going to have patients that are NPO 4 to 6 hours prior to the procedure, and there will be cauterization of the ulcer most likely. For surgical, there may be partial removal of the stomach, and it's usually done laparoscopically. Okay, so let's talk about some medications. Primary purpose of drug therapy is to provide pain relief, eliminate H. pylori infection, heal the ulcerations, and prevent recurrence. You want to see the previous notes on the treatment of H. pylori. Proton pump inhibitors and H2 receptor antagonists and prostaglandin analogs, antacids, are not used in renal impairment though, and also Riopan, which has the lowest sodium antacid. Purpose of the drug is to provide pain relief, eliminate the H. pylori infection, heal the ulcerations, and prevent the reoccurrence. To eradicate H. pylori, it takes a drug cocktail. Tums is a potent antacid, but it causes the release of gastrin, so patients get rebound acid secretion. So it's not a good choice for acid inhibition. Carafate forms a protein complex at the base of a peptic ulcer, kind of like a band-aid. It helps prevent further damage from acid and pepsin. It doesn't stop acid secretion, but it does bind with bile and pepsin, reducing injury from these substances. The main side effect of this is constipation. Herbs such as slippery elm, marshmallow root, quercetin, licorice, they heal inflamed tissue and increase blood flow to the gastric mucosa. Then they'll also need zinc, vitamin C, essential fatty acids, acidophilus, vitamin E and A, glutamine, and these all enhance healing. Some of the shock signs you want to watch for is weakness, thready pulse, hypotension, chills, palpitation, and or diaphoresis. Okay, so now we're going to review GI bleed. The patient who is actively bleeding has a life-threatening emergency. He or she needs supportive therapy to prevent hypovolemic shock and possible death. Nursing priorities are to maintain airway, breathing, and circulation. So you want to be sure to provide oxygen and IV lines, monitor vital signs, monitor hematocrit and oxygen saturation. This image depicts most common causes for GI bleeds. EGD can assist in achieving homeostasis during an acute bleeding episode. There is thermal contact, injection of epinephrine, clipping the bleeding vessel with a clip, and then nursing interventions will include to be NPO 6 hours before, consent is needed. Post-procedure, you're going to do vital signs, check heart rhythm and oxygen saturations, and watch for the return of the gag reflex. So the purpose of the NG tube placement or lavage is to determine the presence or absence of blood in stomach, assess the rate of bleeding, prevent gastric dilation, and to actually administer the lavage. So the procedure will include to apply a lidocaine gel or spray before the tube is placed, confirm placement of the NG tube with an x-ray, maybe giving IV Reglan or Mexarin. It can be given to decrease symptoms while the tube is inserted. Lavage is accomplished by instilling 200 to 300 milliliters of room temperature solution, usually tap water or sterile water, and then drawing the solution back out. Patient lies on their left side, and it continues until return is cleared to pink. You want to see page 1232 of your textbook to review how to insert an NG tube for review. Okay, I'm going to talk a little bit about Zollinger-Ellison Syndrome. It is a rare disease that is manifested by upper GI tract ulceration. There is an increased gastric acid secretion, and one or more duodenal or pancreatic tumors are called gastrinomas. 2/3 of these tumors will metastasize. ZES is caused by gastrin-secreting tumors that stimulate the acid-secreting cells of the stomach to maximal activity. Causes GI ulceration. About half the patients will experience diarrhea, steatorrhea. Usually there's no infection with the H. pylori. You'll see an increased serum gastrin levels. It's medically treated to decrease acid secretion. They use Prevacid or Prilosec or Sandostatin. And then they have the Whipple procedure that may be needed. Okay, I'm going to discuss gastric cancer. Gastric cancer usually begins in the glands of the stomach mucosa. There is inadequate acid secretion with atrophic gastritis, which creates an alkaline environment that allows the bacteria to multiply and act on nitrates in food. Nitrates interact with the amino acids in the stomach to form carcinogenic nitrosamines. These are converted to nitrites. It is by direct extension through the gastric wall and into regional lymphatics, or it is spread by the blood supply, the portal vein, to the liver, lungs, and bones. There's usually a 5-year survival rate. It's poor because most patients have no symptoms until they're late into the disease. Symptoms will include indigestion and abdominal discomfort. Okay, so they may have stool that is positive for occult blood. They could have hypoalbuminemia. They'll have abnormal liver tests. You'll check their CEA. They may get an EGD. The possibility of surgical resection is the preferred method. They may get chemotherapy such as cisplatin and epirubicin. They may have radiation for palliative management. They may get a total gastrectomy, anastomosis of the esophagus to the jejunum. Okay, so we're going to discuss post-op. Head of bed should be elevated to prevent aspiration from reflux. NG tube should be secure and patent and check the amount of bleeding. You want to watch the incision for infection. You will monitor for dumping syndrome. You will check for alkaline reflux gastropathy. You will also monitor for afferent loop syndrome. You will teach the patient to eat small, frequent meals. To avoid drinking liquids with meals. Have patients avoid foods that cause discomfort. Have them eliminate caffeine and alcohol consumption. If the patients smoke, have them stop smoking. Have the patients take vitamin B12 injections as prescribed. And have the patients lie down after eating for a short time with their head slightly elevated. This concludes the lesson of care of patients with GI alterations, part 3. If you have any questions related to course content, contact the instructor.